So I think the story for treatment HER2-positive breast cancer has been changed in the past two decades because currently we have very powerful targeted therapy. And two milestone were diagnosed study, one called Capetro and another Emilia. Two studies have been shown a significant increase both in the progression-free survival and overall survival. As you are a very important investigator in these two studies and have been invited as a co-author, so what's your feeling after the study data release?
So in breast cancer, HER2 is an important signaling pathway. So we call the oncogenic addiction. HER2 is an important oncogenic addition. HER2 blockade is important. So when Herceptin introduced in the combined taxane, there was an improvement in progression-free survival and overall survival. But when the Cleopatra trial was introduced, this might be good, but we did not imagine this is really good. But when my patients, almost 30 patients enrolled in this study, they coming to the clinic more than now. Out of 4 out of 3 patients still being treated in my clinic without symptom, without hair loss. Yeah, that was remarkable. So when the Jose Baselga presented this preliminary data of the Cleopatra trial, I was very surprised. I attended many international meetings when he presented the progression-free survival slide is coming out. Everybody clapping. So this result is amazing, and I think TDM1 is just a very smart drug. The first drug using antibody drug conjugate concepts, so showed approved efficacy not only in terms of progression-free survival and also overall survival, not only in first line, second line, third line. That's very important, effective armamentarium. Other reports, some overall survival benefit was reported in the metastatic eribulin data, but this data is unprecedented, remarkable, practice-changing results, I believe. Yeah, I guess so.
Oh, yes, we agree. So will you comment what's your daily practice? What's your daily practice in the first-line treatment by using the Capetro data? How do you selection patient to give all patient or a special group to give the dual blockade?
So there is no subgroups who gets most benefit, less benefit. So patients who can participate, tolerate the chemotherapy docetaxel. The Cleopatra regimen is composed of 3 regimens: chemo 1, chemo docetaxel, 2 HER2 blockade. So if the patients tolerate the chemotherapy, regardless of disease burden, I think the first standard regimen should be Cleopatra regimen. Yeah, so if the patient is older, who could not tolerate, who don't like the hair loss, then if the patient is HER2 positive and ER positive, TDM1 single regimen can be considered. But if the patients tolerate chemotherapy, willing to get the expected improvement of survival, active mind, then I do not hesitate to recommend the Cleopatra regimen. Yeah.
Okay. So regarding the chemo partner, do you recommend the Taxane will be the best? I mean, maybe we can switch the Taxotere to Taxol or to Navalin combined with dual blockade. Is that okay? Or?
Yeah, I would like to use the combination is Navalin or paclitaxel, but in Korea it is not allowed. So we just prescribe docetaxel backbone plus HER2 blockade, Herceptin, pertuzumab.
Okay, the same problem. The question is about the second line treatment. So how do you choose the second line treatment? In which subgroup do you will recommend by using the TDM1 first, or any consideration in your practice?
Amelia trial showed that efficacy single TDM1 is better than the two-drug combination, lapatinib capecitabine. Not only efficacy in terms of progression-free survival, overall survival, and less toxicity. So in second-line setting, TDM is better than the lapatinib capecitabine. But in Korea, TDM was just reimbursed last September. So TDM1 can be prescribed, especially in rich person. But because it's not reimbursed, we prescribe TDM1 in later line setting. So, now we have a good drug, TDM1. You have a long period of progression-free survival. But when TDM1 is used in later line, our progression is short. So patients asking me why this is short. But after approval, after reimbursement is issued, then the progression-free survival is almost similar to that of the published data.
As you mentioned, the Perjeta and Kesimpta have been reimbursement in your country last year.
Yeah, last year.
So your first choice will be Taxane combined with dual blockade, and followed by the
TDM1. Yeah.
But however, we did not have enough data to support after the dual blockade, the TDM1 still is very good. So do you think that after dual blockade, the TDM1 is also effective?
Considering the mechanism, TDM1, as you understand, the Herceptin can be used beyond progression of Herceptin, still effective. Continuous HER2 block, HER2 pathway is important in the management of HER2 breast cancer. TDM1 targeting the HER2, then intracellular the drug is released, killing the cell selectively, effectively. So I saw that my patients still effective after the Cleopatra regimen treated with TDM1, showed a similar efficacy. Yeah.
Do you do any other laboratory tests to help you selection patient? I mean, such as check the messenger RNA protein level or any else?
When I participated in clinical trial, messenger RNA RT-PCR was measured, but in clinical practice is not tough to in daily practice. Yeah.
Okay, thank you.
So does Korea Breast Cancer Society play a role in the Perjeta and the Kesimpta reimbursement application? Could you like to share the successful experience with us?
It is very tough. In the previous president and the period, they don't care about this. But now, Korean Breast Academic Society very organized. They some committee members. We have this good results. We'd like to have this drug be treated in reimbursed setting, but to do that, we should submit some material to persuade the government. But in the previous time, it was tough. But nowadays, the most important one in Korea is the voice of the patient advocate. Patients call every day this civil officer. It's terrible. So that voice of a patient advocacy group and academic society, in parallel, they work together. They show that educate the patients, especially in the large group of the patient advocacy group. We educate those groups. Those activities, including the physicians' activity, academic activity, and the voice of the patients' advocacy group, made it successful.
Because there are increasing number of treatment options, launched in the MBC setting. So are there any consensus or guideline that focus on MBC?
That is
Korea?
very important. Although HER2 breast cancer was poor prognostic disease by nature, but it is much improved with the HER2 blockade. Still many rooms to improve. So actively, new drug is under investigation. So we'll see many drugs will be in the clinic soon. So prioritization or ordering of the available HER2 blockade will be the issue. We need to discuss in the committee, especially academic community, based on evidence. So now, well-developed country, they treat the patients based on evidence base, but in less developed country, cost-driven decision. Yeah.
As you are the current vice president of the Korea Breast Cancer Society, do you or your society have the interest to cooperate with the Taiwan Breast Cancer Society?
Sure, yes. So I came. So we are holding the conference, international conference, more than lasting 10 years. So we invited key persons, and especially Taiwan, Japan. The culture of society is more central, similar to, that is similarity Korea and Taiwan. So, and nowadays the BIG group in the beginning do not pay attention to Asian group. Now they pay attention to group. So I think Taiwan Society group also participating that international group by Dr. Singh. I already known him more than 5 or 6 years. By meeting several times, so we can discuss more freely, so we can communicate. So with that platform, so we can collaborate more actively, efficiently, and those collaboration benefit could expand it to a young generation.
Okay.
That's
Thank
my
you very
hope.
much.